Hello, everybody, and welcome to London Valves. We have a great session on tailoring mitral and tricuspid dedicated clip therapies by unlocking their full potential. So we have a lot of friends and experts around the table. I'd like to introduce everybody. So starting from my left side, far left, I have Maurizio Taramasso, who's going to be our moderator for the discussion and the link with the audience in case you want to react. I will have, on my left, I have Philipp Lurz, Georg Nickenig, and Johanna Vogelhuber. And remotely, Professor Bekeredjian is going to join us for one lecture. I'd like to start stating the objectives of our session, which is to learn how to optimize patient selection and tailor the strategy according to the anatomical characteristics we will have for this live case experience. We will see how to optimize and actually how we can achieve better results with last generation devices. But also, we need to learn how to maximize outcomes by selecting the appropriate device for the specific patients to obtain the maximum effectiveness. Again, this is going to be a journey starting from the very beginning. We will start 30 years ago with Alfieri introducing the techniques from the surgical perspective until the recorded case which have been done in Bonn with you, Georg. And we will have other lectures which are going to help us through the discussion. Without further delay, I would like to give the word to Maurizio.
Yes, before starting with the program, I would like to stimulate all the participants here, physically present, but also at home who are connected remotely to post the question in the chat. We will not have an official chat master, so the chat will not actively be moderated, but your question will come directly to us on this iPad, and we will try to address the most interesting one.
Oh, thank you, Maurizio. So let me just introduce the day, the end of the day, giving you a little perspective, because I think I would like to share with you an important message. 30 years ago, Professor Alfieri introduced the Alfieri technique. So it's exactly 30 years from the very first procedure. It was one day, he always tells the story, one day when he had this patient with a very complex anatomy. For that time, anterior leaflet prolapse was considered a complex anatomy. Today it's probably not anymore, but 30 years ago we were very skeptical about treating the anterior leaflet. And he was remembering another case that he saw just few minutes before. I think it was probably the same day. It was a patient who came for an ASD closure. Again, we're talking about prehistoric events. We were still closing the septal defect surgically. And this patient had a congenital double orifice mitral valve, which was perfectly functioning. So getting the inspiration from this patient, he basically developed the idea of fixing MR by joining the leaflets at the site of the regurgitation. You can see here a couple of papers. I think I think the most important one is the one on top, and also those pictures are pictures that I have been doing together with a nurse many years ago when I was really starting my practice. And in this paper, we actually predicted the possibility to adopt this technology, this technique, for an endovascular approach. And since then, a lot has been happening. Actually, a few years later, we wrote the idea of percutaneous approach in 1998. Actually, the paper was written in 1997. And 2003 has been the first in man with E-valve. Since then, there have been a lot of different studies. There have been multiple iterations of the technology, but more importantly, more than 100,000, almost 150,000 patients treated worldwide, not only mitral, but also now tricuspid, with more and more experience, more and more streamlined procedures. So that today I can really think and say that this device allows us to treat patients not anymore with a palliation, but really with a treatment which can be at least as good as surgery when the patients are well selected. So with that, I'd like to stop my short overlook of the 30 years of MitraClip. And I'd like to start our journey tonight looking at the patient. So we're going to look at one patient which has been treated in Bonn. And please show us the video of the case presentation.
Welcome everybody to the Heart Center in Bonn to another case, a tricuspid regurgitation case. On my right side is Sebastian Zimmer, Marcel Weber in the back on the echo machine, and without further ado, he's gonna introduce the case to you.
Warm welcome from my side. We have a 80-year-old patient. He has heart failure, which was his last time in hospital admission in June of this year. He has 3 vessel CAD with redo CABG in 2000, and last time he got a stent in the RCA in 2020. And he has a multiple history of myocardial infarction and persistent AFib with a high CHA2DS2-VASc score of 5. He has as well an abdominal aortic aneurysm with around 35 millimeters and a chronic kidney failure stage 3. He's suffering from severe dyspnea, NYHA class 3, has leg edema and feels tired every day, and has a high operative risk with a Euro score 2 of 15%. On the next slide, I can show you the videos of his tricuspid valve, and he has severe functional TR with a PISA of more than 9 millimeter and an Euro of more than 19 square millimeters. We have a small coaptation gap of just 3 millimeters and a coaptation gap area of 0.4 square centimeters. Left ventricular ejection fraction is reduced with 40%. TAPSI is 15 millimeters and systolic pulmonary pressure is 41. So may I summarize? 80-year-old patient after 2 times CABG with highly elevated operative risk, presents with symptomatic severe functional TR and dyspnea. So we had to go for tricuspid edge-to-edge repair with a TriClip G4 system. Thank you.
Okay, thank you very much, Marcel, for this nice and detailed introduction. So that's a typical suspect for tricuspid regurgitation, elderly patient. Long-standing atrial fibrillation is one of the most important comorbidities of these type of patients. And then commonly these patients suffer also from left heart disease. One very important, attractive possibility to treat this patient is with a TEER device. And the one device which is really dedicated for the tricuspid space is a TriClip.
Okay, so you already, Georg, you already alluded to the option of treating these patients with TriClip, and I'd like to start from the very beginning. So I would like to ask already Maurizio to comment on this patient. Is you have been collecting data from different devices for a few years now in the 3-valve registry. Is this a typical patient going to our interventions?
Yes, I think from both clinical and anatomical standpoint, from clinic is definitely a high-risk patient for surgery, redo CABG, multiple copathology, elderly patient, symptomatic under optimal medical therapy, let's say maximal medical therapy, because what is optimal medical therapy in this context is debatable. And also from an anatomical standpoint, as they showed in the case presentation, the quality of the imaging is excellent. And this is an important element to be considered when selecting leaflet therapy, especially edge-to-edge therapy like TriClip. And also the gap, coaptation gap, which is probably the most important predictor of procedural success or failure, it's pretty much favorable being 3 millimeters. So probably the patient was also really well optimized for the procedure. But anyway, this seems to be a good candidate to me.
And Philip, I also would like to get your opinion about this patient and in general, if you see this kind of patients, if the patients you see today are the same patients you were seeing 5 years ago in your practice for tricuspid, do you see more patients coming to your practice? Is it this population changing as we go forward?
Yeah, that's a very good point, because it does change. It really does change. At the beginning, we've seen patients at the very end of the spectrum. They were referred at end-stage right heart failure, many of them, at the time where surgery was not even worth talking about, but also possibilities of any repair were quite limited because of the gap, because of RV function and the general status of these patients. So I think what we achieved for sure, amongst many other things in the field, we achieved increasing the awareness for the disease. We increased the awareness of tricuspid regurgitation as a terrible disease to have, but also managed to spread the news that now we have something to offer these patients. And we see that patients more coming through, and they tend to come a little bit earlier.
That's good. And now I will ask Georg and Joanna. You have many options for these patients. Triclip Triclip is the most commonly used in clinical practice. There are also other options. What makes these patients specifically eligible for Triclip procedure? Is it because of the amount of data we are accumulating? Is it because of the maneuverability, because of the technology? What are the key elements for choosing Triclip in a patient like this?
In this particular example, we saw in the transgastric views that the location defect was typically for functional TR in the anteroceptible commissure and a little bit towards the center. And this is very typically for functional TR, and especially good to treat with transcatheter edge-to-edge repair. And moreover, we saw the diameter of the annulus wasn't that severe, so it wasn't a pronounced annular dilation with a septal lateral diameter of 42, and the other way to treat it could be with an annuloplasty device, but in this case we have a very specific and located coaptation defect, and the annular dilation wasn't that severe, so I think it was the best way to treat it and to minimize complications as well, because he has multiple comorbidities. We want to make it as easy and as safe for the patient as possible.
This brings back again the recipe of success, which is not only expertise. We have a lot of experts around the table, but also patient selection is crucial. And now the last question before we go forward to you, Georg. Are you becoming more selective, or you are expanding more as you go forward? You know, on one side, obviously, you tackle more complex anatomies, but on the other side, you're being burned maybe by decisions in the past. So what's the recipe there?
I think the recipe is try to get more selective and try to really admit to yourself that it is not very easy to treat a torrential TR with any device besides replacement. And even replacement has its issues there if the patient is far gone with right heart impairment, with severe right heart impairment. And therefore I would be a bit more selective. But there are still many no option patients, as we all know, and their palliation, bringing the TR from 5 to 3 means also a lot to the patient. So, but in general, I would try to be a bit more selective.
And this gives me the opportunity to go the next session, next lecture, which is going to be on technology, because honestly, on one side, we become more selective from a clinical perspective, but from the anatomical perspective, you have more options, and we have also more experience. So with this, I'd like to invite Professor Bekeredjian to review the latest novelties in this field and what can be achieved with the latest generation MitraClip and TriClip devices.
Yeah, thank you very much, and also a very warm welcome from my side here to London. And I'm really happy to be able to join you this way. So, if we look at the history, which has already been mentioned a little bit, we know that we have many years of experience now with the MitraClip system, with all these different generations that really helped to have more technical options. And also we have this vast amount of data, randomized trials and registry data. For the tricuspid valve, if we look back for decades, we only had conservative treatment, which was basically no treatment, just being diuretics mainly. And we know that some compassionate use cases with the MitraClip system have been performed in the tricuspid valve. Unfortunately, now we have this new dedicated concept to treat the tricuspid valve. If we quickly look back to the MitraClip system, the 4 different generations, all of you in the audience also have seen these options. We started with very early systems that had less steerability, and with the further generations, we got more steerability, an improved device situation, different sizes that are now available, and also different options with the Gen 4 system to grasp separately. So if we look at the last generation, the Gen 4 system of the MitraClip, which is also the base for the present generation of the TriClip system, we have 4 different sizes. We have a simplified procedure, and we all know that the less procedural steps you have, the less complications you cause. We have a very good steering option here, and also we have the option to measure the left atrial pressure, which I want to quickly demonstrate here. We see these recesses in the guiding catheter, and the guiding catheter is placed in the left atrium at the tip. So this allows us to basically measure the left atrial pressure during the implantation, and that's quite helpful to judge a good result of the implantation. And you can see this here with a left atrial pressure measurement at the moment of the grasping of the clip, and it's easily seen that the amplitude and the pressure level of the left atrium decreases. And this is always a very good sign if you see that, because it helps you to understand that most likely this clip will have a clinical benefit. Normally, you would also see an increase in arterial pressure at that moment. And in addition to the echo images, this is always a very good, helpful element to judge if the clip position is really good and if the patient will most likely benefit from this clip. So, as I quickly told you already, there have been some attempts to use the MitraClip system in the tricuspid position, which is sometimes feasible, but everybody who has ever done that before knows it's extremely challenging. It's very often resulted in suboptimal implantations, and basically it was very often not possible at all because the distance or the angle was not correct. So the main problems which have to be achieved were to achieve the right distance to the tricuspid valve, so not too far away, but not too deep in the right ventricle, and also to achieve an orthogonal entry into the tricuspid valve. So these were the main challenges in developing the TriClip system. Unfortunately, this was also used then as a base to develop the TriClip system. The first generation was still more or less based on the MitraClip NTR XTR concept, and the second generation that is now available is based more on the G4 system that we know of the MitraClip. So if we look at the G4 TriClip system, we have 4 different sizes again here available, and very interestingly, we have a very specifically designed distal curve of the catheter, and I'd like to quickly show you why that is important. We need to get completely different angles to reach the tricuspid valve when coming from the caval vein, from the inferior caval vein. And this was one important step to develop a catheter that can have this steep angle to enter the tricuspid valve. Also, we have 4 different sizes, which is very helpful because we can address different anatomies and different pathologies. And we all know by now that the tricuspid valve is much more complicated anatomically and has a lot of variability, which we are not used in that amount with a mitral clip. So having 4 different sizes is helpful. In general, one can say that most likely the larger sizes are being used at our institution. For example, 70% of the clips we implant in tricuspid position are XTW clips. Also very helpful is the option to not only grasp both leaflets simultaneously, but also to grasp them separately. While we have this option also in the mitral clip G4 system, it is not used that often because in general with a mitral valve you can very often have a simultaneous grasping, which I think is also superior in that situation. But the challenging anatomies in the tricuspid valve, especially if you have large gaps, make it easier or more important to have this separate grasping, and this can really help to achieve good results even in extremely challenging situations. Here's an example of a separate grasping. We are first grasping here the lateral leaflet. This was a patient where both leaflets were not being able to grasp simultaneously. Now, after the lateral leaflet has been grasped, the clip is turned to the septal position, and you can now see how the septal clip the gripper went down, and we're now closing the clip. And this was the only option for this patient, for example, to have an edge-to-edge repair despite this large gap. Another aspect that is completely new with the tri-clip system compared to the mitral clip system is the Slnov on the guiding catheter. This doesn't exist on the mitral clip system because it's simply not needed. This Slnov allows us to have a septal lateral movement of the guiding catheter, which is sometimes necessary, I'd say more or less in 30–40% of the cases, and allows us to have a more orthogonal entry in the tricuspid valve. One of the specific challenges which we had in former times when we tried to use a mitral clip in tricuspid position. And I'll show you an example here. This is a situation, you can see it on the right picture where the Slnov is being used. The angle is now getting more orthogonal, and this is the situation which we then achieved in order to get really orthogonal into the tricuspid valve and be able to grasp both leaflets. The tricuspid valve does not have these recesses in the guiding catheter as we just saw in the mitral clip system for the LA pressure, but that's not necessary because in the tricuspid procedure, the anesthesiologist, of course, has a central venous line, and also we have an arterial line. And what you're seeing here is in yellow the central venous pressure, and in blue the arterial pressure. And very nicely you can appreciate that when grasping 2 leaflets, the central venous pressure drops, the amplitude drops, and also on the blue image you can see how the arterial pressure increases. And again, this is extremely helpful to judge a good clip position, and this would normally result in a clinical benefit for the patient. And thus I'd like to summarize that for the mitral valve, we had seen the 4 different generations of mitral clip that really improved our work with the mitral clip immensely during the last years. We also have this monitoring of hemodynamic effects that also helps nowadays. And with the tricuspid valve, we are very happy to now have this dedicated tri-clip system, which is extremely precise, allows us an anatomically accurate positioning of the clip, and it enables us to really achieve success in most cases where we attempt attempt a edge-to-edge repair in tricuspid valve position. Thanks.
Well, thank you very much for this overview of the technology. I think we all happy with the new technologies, but let's see how this technology basically behave, what we can achieve with these technologies, what are the clinical outcomes. Is there any evidence that this improved technology is improving outcomes? And this question will be answered by Philipp Lurz.
Thank you. So you've heard that we are in a great situation having the G4 devices on our shelves, the latest iteration, the improvements as demonstrated, and most importantly, 4 different sizes, longer arms, wider arms, to tailor the therapy, potentially create larger tissue bridges, and thereby also be more effective, but keeping the safety we've seen previously. Now, whether that's the case, I'm going to demonstrate in the following. Obviously, that was assessed very thoroughly in the EXPAND G4 registry. This is a global approach, a global real-world registry, pretty much looking almost on, at all comers, very unselected, so it's probably as close as it can get to reality. And remember, the study is still enrolling, but here I present the 30 days results of the first 343 patients. Now, here you can see the implant rate, success rate, 97%. Acute procedure success in terms of reduction in mitral regurgitation, that was defined a reduction to moderate or less, 97.4%, with a very short device time and also a pretty short hospital stay. So overall, that's probably the best results we've ever seen with that therapy. And we always talk about it's good to have 4 sizes to tailor the therapy, and indeed it's not that we only use one device size, length or width, but in fact all these 4 clips were used, suggesting that indeed the interventionalist tries to tailor the therapy to the anatomy which is treated. And in many patients, different device sizes were used when more than one clip is implanted. Now, I think when we started, and for the longest time, we also defined success bringing down mitral regurgitation to moderate or less, but I'm not sure whether this is still state of the art. I think, and this is backed up by clinical data, that we should bring it down to mild in every patient where it is possible. And here you can see that the percentage of patients in whom mitral regurg was brought down to mild or less was 90.7% in that registry. So that's, again, the highest number in that respect seen so far. We've heard about the ability of do independent cripper actuation that has been used, but it should also be mentioned that the default approach is still simultaneous activation of the crippers and thereby grasping the leaflets. Now we switch gears a little bit and look at the tricuspid valve, which, as you know, due to its anatomy and the support in the right ventricle, or actually the missing support in the right ventricle, is doomed to become incompetent in a large proportion of patients, and that is associated with a very poor outcome. The Trilumina trial, looking at the safety and efficacy of edge-to-edge repair in these patients, a trial which certainly paved the way for the whole field, showed that this can be done with very good safety data, very few major adverse events, considering how fragile these patients are, 7% the rate of major adverse events at 1 year, but also the durability of TR reduction was well maintained at 1 year, where we see a great, at least 1 grade TR reduction in 87% of these patients. Now, the nature of these trials is that the anatomies are a little bit limited, a few centers are participating, and they're quite strict inclusion and exclusion criteria. So the question is, how does that perform in a more realistic approach, looking at real-world practice? And that was the task and aim of the Be Right study. Also a study still enrolling, looking pretty much at unselected patients. And here I can demonstrate the results of the first 200 patients. In that study, the dedicated TriClip device was used. That's the summary. of the results of the first 200 patients enrolled in the BeRight study. The patient population was certainly as sick, maybe even sicker than what we've treated in the Triluminate trial. We see again a perfect safety profile with only 1% of subjects experiencing major adverse events. And again, we see a 88% percentage of at least one TR grade reduction. When we are a little bit more strict to ourselves and look at the percentage of patients in whom TR was reduced to moderate or less than 66%, considering the complexity of the anatomy, this is good, but I think we also can do better in the future. What's worth mentioning that these encouraging results were achieved over a wide range of annular dimensions and also in those patients in whom an RV lead was present, very good acute procedural results. So the mere presence of an RV lead certainly is not an exclusion criteria. It's the opposite. You can still achieve good results. And the TR reduction resulted in clinical improvement as expected, significant improvement in NYHA class and quality of life. So in conclusion, these dedicated devices allow us to tailor therapies to achieve the best clinical outcomes. We see very good real-world outcomes in the EXPAND G4 and BeRight study, confirming what has been shown in previous more selected patients. Thank you very much.
Thank you. Thank you. Thank you, Phyllis. That was very useful to really put this technology now into perspective because, again, often we see some little improvements and we ask ourselves whether this really make a difference, and these data are promising. Obviously, we need to look more forward. And again, I think this field overall is a field which is evolving. I'd like to remind that we spent 1 year together with the PCR focus group Tricuspid, really to exchange ideas and knowledge about the tricuspid valve and the issues with all the aspects of the lifetime management of these patients. And when I see this, the outcomes that you just shown, now I will ask again, Georg, but before we look at what happened during the live case, I'd like to ask Georg, when you see these outcomes, do you feel safer and more keen to offer these procedures to patients with more challenging anatomies?
Of course, because the major difference to the Triluminate study is that we have this elaborate system available by now. So larger and wider clips, which enables us to treat more complex and challenging anatomies. That's for sure. But again, we have to wait for more clinical data. We enrolling the patient in these studies, in these registries, but the very good news is that there is a randomized trial even running, the Triluminate Pivotal, and if you recall the past, usually we needed like 10 to 15 years to come up with a randomized trial looking at hard endpoints, and here we have this trial already up and running, and this will show us whether also this more desperate type of patient will benefit clinical-wise with hard endpoints. But yes, we are a bit more encouraged, but still we need to be cautious. If you want to have really good results, go for the serious and maybe massive TR patients.
That also opened one question about center of excellence, let's say centers who are dedicated to tricuspid interventions. As we see, the topic is becoming less uncommon. So the so-called forgotten valve now is not anymore forgotten. This year at London Valves, we have a lot of space dedicated to tricuspid interventions, tricuspid disease, and there are a number of activities around this pathology. And obviously, there is a lot to learn still. The point is, what change in your structure did you have to change anything in your heart teams to accommodate this kind of patients? Let's start with Philip. What happened in Leipzig?
I mean, we had a quite successful heart team in place before we started, but that was probably the reason why we were able to start the program pretty much from scratch and with good results at the beginning. Obviously, a lot of learning, but at least we were able to learn and perform the procedures safely. The most important factor, what's different to other procedures, is imaging. Imaging is absolutely key, and there was a lot of learning to do. And what should also be mentioned is the fact that obviously imaging guides us as an interventionalist, but for these procedures you can also use fluoroscopy to guide the imager a little bit. So it's a very nice procedure if you would like to build a very strong relationship with your imager, because it goes in both ways.
And then, Maurizio, we've been struggling at the beginning, like everybody else, with these procedures. Now, if you want to suggest somebody who never did this procedure before, what needs to be established to start taking care of these patients? What are the basic suggestions you would give to a new center who wants to engage in this procedure?
Obviously, the first important aspect is to increase the awareness of this kind of optimized technology, which are safe, not only effective, but really safe, among the people outside the hospital who are referring the patient for this kind of treatment. So they should be aware that we have now a really effective possibility to treat this challenging population with a really reduced chance of getting complications. So it's a really safe procedure. And then, as Philip said, to establish a really well pathway of involvement of the imagers, which is more and more important in this kind of procedure, as well as to make aware the operator, which are maybe already experienced with other valve, that the language and the nomenclature in this valve is somehow different. So to make a kind of common language from the patient selection to the procedural guidance makes, I think, helping in the success to start the program.
Imaging as usual is probably the key element, and is helping us to somehow guide procedures, get the right strategy, and obtain the maximum. Before we go into the technical discussion, I would suggest we look at this procedure so that we really go into the real case. And so we will have time to exchange also a little bit of our ideas about how to perform these procedures, because obviously there are many different options that we have. We're still learning how to tailor our therapies. So I would suggest that we watch the video now.
Usually we use the large device, and that's what we're going to do today too. It's an XTW device. So what we did a venous puncture, advanced a stiff wire into the vena cava. The sheath of the tri-clip device, it has another possibility for steering. Now we have the possibility to go also to the lateral side or to the opposite side with that device, and usually we are able to prevent the septal hugger. Now we can bring it down. If you concentrate on echo.
It's a bicaval view, and now you come down to the valve. I show you in the distinct commercial view on the left side.
So what we need up front are these two very standardized views. One is the commissure view. On the left side you can see the aorta in the middle, which is anterior obviously, and on the left side is posterior, and there you can see the device. It's coming in a already nice trajectory.
On the right-hand view, you're a little bit septal with your device.
And now we can steer from the septum to the lateral just by maneuvering with this sheath. And as I said, it comes a bit from the septal side, and therefore we apply a bit of lateral steering to the device and correct that by going again to the septal side, and that gives us a better trajectory. Marcel, now we did a bit of maneuvering. You could explain what you see and what you think about the trajectory.
So first of all, I tried to go through the clip and shorten the distance between the probe and the clip. On the left-hand side, the commercial view, and on the right-hand side, the four-chamber view. It's somehow a reversed four-chamber view, and there the clip trajectory is very good. You see that it's just in the middle and just pointing to the valve. And you open it right now. I tried to...
I mean, that's the same as in the mitral spot. We have independent grasping, which is a very good thing, especially in the tricuspid space.
This was septal.
Okay, very good. And now, next step would be to orientate, first of all, the tri-clip in the right position and bring it also to the right spot of the tricuspid. The major spot of the regurg is at the central part of the anteroceptible commissural line.
The triclip is just in the middle of the valve. Now you see a good cross-sectional view of the tricuspid valve. Here on the right-hand side, about 9 o'clock is the septal leaflet. At 12 o'clock is the posterior leaflet. And on the lateral side, there seem to be two different leaflets. On 9 o'clock, there is a commissure. And we believe that the main spot of the TR is here between this anterior leaflet at 6 o'clock and the septal leaflet at 3 o'clock.
So if we look at 9 o'clock at this commissure, is that the commissure between the anterior and the posterior leaflet, or is this A1 and A2 leaflets?
I think the posterior leaflet is divided into two scallops.
I advance the system a bit, counterclockwise turn it a bit, that we are in the right orientation. And if you look on the right image, you could estimate how deep we have to die.
Clock a little bit counterclockwise,
like
so
this,
that you had to 2 o'clock and 8 o'clock. Now you have
the lateral is on.
Yes.
So we are closing the cripper. And
I think that the septal leaflet is on.
Let me just try to make it a bit better. Now I think we have also the septal leaflet, and Sebastian is going to close the device.
Very good.
So there are two different approaches. You always have to go transgastric, because the transgastric view is extremely instrumental for the whole procedure. It tells you where to go in the valve, and it tells you how to orientate, how to rotate your device in relation to the commissures. And then once you have done that, you can go back to the transesophageal views and then do your grasping procedure. But if you have this very brilliant images as Marcel is providing right now, you can also go for the grasping maneuver in the transgastric imaging.
So I think that the clip is right in the middle between the anterior and septal leaflet, and here you can see how the leaflet goes into the clip here, and you're in the central part of the anteroceptible commissure. So I think it's a very nice grasp.
So that's at least what we aim to do.
Should I show color?
Yes, please.
So I have just a small remaining central jet. You can see it on the left-hand side. Okay, I changed to the transesophageal view. So compared to the baseline images, there's still a remaining central jet, but I think it's very small.
That's a patient where you can really come off the table with a mild TR. We all know if the patient has torrential TR and a coaptation defect of more than 1 centimeter, sometimes 1.5 centimeter, it's not possible to reduce that with a TEER device to a moderate or mild. That is very difficult. These patients are too far gone and usually are not treatable with a catheter-based approach. Quantify the gradient, Marcel?
Yes. It's a sinus rhythm, so the gradient is quite low. I will measure it. It's about 0.3 millimeter of mercury.
I don't think that we are forced to do anything else. I think that is the optimal candidate for a TEER device where you place in the anteroceptible commissure a device, and we know that this impacts also majorly the annulus, because you can nicely pull the annulus from the lateral side to the rigid septum. So I think that's a beautiful result. We have only mild TR left. Marcel, what's your opinion?
And the coaptation is very good. You can see how the leaflets approach the center of the valve, and there's no remaining gap and just a small and residual TR.
We're gonna free the clip. So now we release the clip. We can show that also simultaneously on fluoroscopy. Looks pretty stable. So this is the final result. Marcel, you want to comment again?
Yes, the clip is very stable between the anterior and septal leaflet, and there's this small central jet which became smaller, I think, after clip release.
I think it's a nice result. Patient will be extubated on the table and then go to our ward and hopefully leave the hospital in a few days from now. So thank you very much, Sebastian, Marcel, for the collaboration. Thank you very much, you, for your attention. Bye.
Outstanding procedure, done very well. I would say there is, when you see these kind of procedures, you understand that there is a lot of knowledge behind. There has been a lot of learning curve, and there is also been a good patient selection, because actually a single clip in the right position achieved a very important outcome. I like to have, now it's open for discussion for everybody, but I will start with one question that comes from your comment. There are different ways to treat these patients, and let's start with a very general one. So we started years ago addressing the anteroceptal commissure in all cases, because this was the only one that was really easy to achieve at the end of the day. In this particular case, you said we put the clip in the commissure, but actually it's not anymore the commissure. You go in the middle of the leaflets, in the chordal free zone of the anterior and the septal leaflet, to achieve a central approximation, and that makes a big difference. And this is obviously doable only with longer clip arms. How often you go for this approach, and how often you have to go for a kind of clover technique? I would like to remind that clover is the denomination, again, invented by Alfieri. So I'd like to once more remind Professor Alfieri as the father, at least, of the concept of leaflet approximation. So how often, Georg and Lurz and Philip and everybody else, how often are you forced to go more than just one leaflet approximation? Georg, you start.
I think we don't have really systematic data on this. We have the data how many clips were used in the studies, and usually it is roughly about 2 clips, and most of the clips, roughly about 80% of the clips, go into the anteroceptible commissural line. That's why I spoke about the commissural line and the central part of the commissural line, not the commissure. And I would estimate that probably in 50% of the cases you have to start a bit more towards the commissure because it's just too wide. That was a perfect example, a perfect patient for getting away with just one more or less central clip.
Is it the same in your practice? Do you always start, if you have a long line of malcoaptation, starting from the posterior septal commissure to the anterior septal commissure, do you always start the anteroceptible or you have different approaches?
I always start anteroceptible, and I'm a strong proponent of the approach to use leaflet approximation edge to edge to reduce annular dimensions, exactly as we've seen here. It's really a beautiful case with a great result with the XTW, so more tissue bridge, which also helps to pull over the RV free wall. And what we've also seen here, and this is why it works so nicely, the clip orientation, obviously in an orthogonal way to the line of coarctation, but also pointing towards the center of the septum. That's something which was illustrated very nicely. And this is why the procedure is so successful. It's not just a leaflet repair, but we get the annular reduction for free.
We have a question from the audience coming finally from the chat regarding patient selection. It's not specifically for TriClip, but in general for this kind of transcatheter treatment. Which is the role of right heart catheterization? Do you do it systematically? How can you guide your decision?
Great question, because actually there is a rejuvenation of right heart catheterization. The young interventional cardiologists, they will have to learn again how to perform, but more important to judge right heart. So probably, I look at you, Jana.
Yeah. So the right heart catheterization is a key element during the evaluation of tricuspid regurgitation, especially because we want to see whether the pulmonary pressure is pre-atrially or not, as post. And so that's the main reason for the right heart catheterization, especially in patients with tricuspid regurgitation, because we can pre-decide, it's a predictor whether the patients might benefit from the tricuspid regurgitation or not. So we do this for all our patients who come to us for tricuspid evaluation, of course. Yeah.
And what are the limits then? So when is a patient not eligible according to the right heart?
Yeah, so there's not a real cutoff for the pulmonary pressure, especially. So there are studies who make the cutoff at roughly about 60 or 70 millimeters of mercury, but there's not a real cutoff for the patients with post-pulmonary hypertension. But if it's a pre, then we should be very, very cautious to treat those patients, yes, especially.
Philip, you have been publishing in this. So what's your actual take on hemodynamics?
We do it in all, because I think it is important also for the prognosis of the patients, also how you consent them, because we've seen that pre-capillary has a certainly inferior outcome than post-capillary. So actually, you need to make a strong argument to treat those with pure pre-capillary at all. So normally we don't treat them anymore. And I totally agree. It's not in terms of PA pressures. It's not a cutoff per se. It is the differentiation between pre and post-capillary. And then another finding, comparing the echo pressures and the invasive pressures. If you see that echo underestimates pulmonary pressures, and we call it a discordant diagnosis of pulmonary hypertension, that's also a predictor for worse outcome. So you need certainly both echo and right heart cath.
And Maurizio, is right heart catheterization in your practice a must? You do it in every patient, or there are some patients where you don't need this?
I think it should become more and more a kind of must for achieving good outcome. Also because there is quite often, and Philip showed this very well in some publication, discrepancy between what you see at echo and what you see with invasive catheterization. So I think as long as we want to become focused on this therapy, should become really a must. We have some other questions from the chat now are coming. And one is maybe technical, but I think it's interesting because we always talk, and Philip showed this very well, that we can clip the patient if there is a pacemaker lead already present most of the time. But what about the opposite? If there is a clip in position, is it difficult in tricuspid then to put a pacemaker? Or should you go for, I don't know, epicardial? Obviously not, but if you...
No problem. I mean, you use fluoroscopy anyway during the procedure, during placing the lead. That's no issue.
And then another interesting question is regarding the right ventricular function, not only the pulmonary pressure, but also the right ventricular function. How to assess it and how to use it in guiding, again, patient selection.
So this is a difficult question, so who wants to take it? You, Philip?
I make a short answer.
You like the difficult questions?
Yeah, because I will make it easy for me. The short answer is that we don't have a proper cut-off value where we should not treat them anymore. But if you want to know and assess RV function properly, then you should do more than TAPSI for sure. You need a global assessment of right ventricular function, either MR or CT or 3D echo, but not just TAPSI.
We talk a lot about optimizing patients, and I think it's becoming more or less a standard. If you have a patient with very large annulus and wide gap, you bring the patient to the hospital, you diuretize the patient, you give maybe sometimes inotropic support and vasodilation. I wonder if anyone is assessing RV function at the beginning of this process and at the end of the process, if there is any evidence that optimizing patient really changes the outcomes.
I think nobody knows. There is no data out there for medical therapy. Maurizio just referred to that at the beginning of this session. I totally believe it would work. It would also alter hard endpoints. Just nobody has done this. And what we know is you can, of course, change dimension of the right ventricle, of the right atrium, right ventricle by diuresing the patient intensively or dialysis patient to do more dialysis to get him rid of more volume. And even general anesthesia changes the dimension of the ventricle, maybe not the function. Maybe not the ejection fraction or anything else, but I'm absolutely sure, and that is one of the major issues. It is such a dynamic disease, and the annulus is dynamically larger or smaller, as it was, by the way, also in that patient. And this is due to volume overload or to a proper pretreatment.
And I have another last question for you, coming from the case that we just shown. You have been using transgastric view for grasping, and you know, for those who have been starting this procedure, we were always using most only transgastric. Now there is another option, which is the inflow-outflow with X-plane, which actually is more a standardized approach, probably easier to understand for the newcomers. On the other hand, I feel like that I see better transgastric still today. So what is your opinion, everyone? Are you switching from transgastric to the inflow, outflow, and X-plane, or you still like transgastric? And like me, I think people who want to do this procedure, they need to understand how to evaluate transgastric grasping.
Yeah, I agree. I like the transgastric view the best. Because the advantage is that you can see all the leaflets of the valve in one view, and if you add the X-plane view, you can also see the chordae and the papillary muscle, and this is a real good advantage, especially for navigation, for helping to guide through the chordae, so there's no entanglement, and you can also really good see the point where the coaptation defect is, and so I think the transgastric view is a really good advantage, and it adds up to the best way to guide the interventionalist through all the obstacles there.
Just one comment to that patient. Our patient didn't have nice transesophageal images on the table, on respirator and whatever. For the shortness of time, we didn't mention that, and therefore we were more or less stuck to the transgastric view.
Well, it was a great picture, and transgastric shows you the chordal free zone, so really you can grasp leaflets very well.
I agree. I think you can get away with not optimal esophageal images, but you hardly ever enjoy your procedure when you have very bad transgastric views.
That's for sure. Okay, so it has been a quick overview, but very dense of information about these new technologies. I think we shared with you the latest novelties in the field of transcatheter tricuspid treatment. We've seen what can be achieved with the latest generation devices. We also reviewed the important tips and tricks to run a procedure safely. I think based on this, I think I can really read more or less the conclusion slide that I believe that transcatheter edge-to-edge is today an established therapy. It's not anymore a palliation. You know, once we understand this, we have a big responsibility. We need to be perfect. We need to achieve perfection. There are tools to approach perfection. And being together, talking together, exchanging ideas is the way to go. And I think there will be a great role for these interventions in the future. With this, I thank you very much for your participation. I look forward to see you in person.